Hi, I'm going to talk about patellar luxation, and we'll get right to it. So we'll start with the anatomy. This is a bone model of a hind limb of a dog. This is a condition that does affect cats too, but the vast majority of the time that I'm working on it, it's in dogs, so we'll use that as our prime example. This bone model happens to show some abnormal anatomy that we'll talk about a little bit, but it'll be perfect for purposes of just kind of showing us the ropes of the players that we're talking about. The way that I think of patellar luxation, and this is really important, is I think about it in terms of the relationship between the long bone anatomy, femur and tibia, femur, tibia. We'll step back just a second and say this is the hip of the dog right here, and we're up top coming down through the thigh, femur, knee joint right here, or stifle, and tibia here. And this is facing forward, so the dog would be walking this way. I think of patellar luxation in terms of the relationship between the anatomy of the long bones, femur and tibia, and the quadriceps mechanism or patellar apparatus, these soft tissues here. It's probably the most important concept when understanding patellar luxation, is that if we have a good match and alignment between these bones and this strap right here, which we'll talk about in more detail, then we have a normal situation. This is the patella right here. It's what's called a sesamoid bone, which means a floating bone, different than most bones in our body which connect to each other via ligaments. This bone has a totally different purpose than supporting us. The purpose of the patella is to take all of the power from our thigh muscle, our quadriceps muscle that's represented here, and as that muscle shortens, which is what all that muscles really do, shortens, the action of that muscle is to pull up on the tibia. So we've got a muscle here that comes down and eventually attaches on the front of the tibia here in an area called the tibial tuberosity. It's a piece of bone in the front of the tibia that you can touch on your own front of your shin right here. As the muscle contracts, it takes the knee from a more bent position or flex position to a straighter position. Now intuitively that would say that's what helps us kick forward, or even you can imagine helps us rise up from a bent position. But also importantly, it's part of every time you take a step, because when you walk, if you don't tighten your quadriceps muscle, your knee's gonna collapse. So even just to stand up and push off against gravity, you're always using your quadriceps muscle. So what does the patella have to do with that? Well, when the muscle pulls, it's just a big mass of contracting tissue, and it will pull depending on where it's attached. But what the patella's evolved to do is take all of that force and concentrate it in one area. So it focuses that force through this little bone, and it efficiently places that effort into one particular action. So it's just a way of using the muscle efficiently, and the body's always keen on efficiency. Evolution's keen on efficiency. The less energy you have to use to maintain a certain amount of muscle, by making that muscle more efficient, the better. So the patella just makes the thigh muscle more efficient. It directs all the forces from the thigh muscle into a very particular spot to provide a very specific action without a lot of wasted energy. So you've got your quadriceps muscle. This is the front of the femur bone right here, and I keep rotating it back and forth. So now the front's facing you. You have your patella, which is kind of embedded in the end of the quadriceps muscle. And then the next little bit here, from the kneecap patella down to the tibial tuberosity, is the patellar tendon. Some people call it patellar ligament. That's the part that focuses this little bone's force through the muscle down to this little piece right here. It all gets directed in one place. The patella normally is confined without being attached, just confined within this little groove of the femur. So if you look from what we call a skyline view, there's a dished in area in the bottom of the femur bone facing forwards. That's the trochlea or trochlear groove of the femur. So in order for the patella to do its job, it should be maintained within that groove. So it just goes up, down, as the muscle works and stays in that groove. Patellar luxation is when the patella can go out of the groove, which is abnormal. Not only does it affect the way the muscle works, but probably even more importantly, it causes wearing of the surface cartilage, both of the femur and of the patella itself. Both have a layer of joint or articular cartilage that can get worn away pretty easily with this condition. And once it's gone, it's gone. That creates inflammation in the knee, which creates arthritis and pain. But patellar luxation itself also can be painful. The characteristic symptom of patellar luxation in dogs is that when the kneecap is in place, everything looks normal. So they usually look pretty darn normal when things are in place. But when the patella luxates, typically the dog will hold the leg up completely. There's a lot of exceptions to all that, but the characteristic sign of patellar luxation in a dog is intermittent non-weight bearing lameness. So a skipping gait, walking along normally, up off the leg, couple steps, back down again. And it's very variable depending on the severity of the condition. So some dogs will skip, once in a while. Some will do it regularly throughout the day, and some will have bouts where they hold it up completely for a while. But that's the most common symptom. So when we think about addressing this condition, it's obviously a very mechanical situation. It's not something that we're going to fix without physically fixing it. So we're talking about surgery. But the things that I think about when we, think about how to treat it is, well, what is the relationship between these soft tissues and the bone? The soft tissues attach up above the femur, up high near the pelvis, and then down at this tibial tuberosity. And they're always kept somewhat tight. So they always follow a completely straight line between those two attachment points. That's just the nature of what an elastic piece of material will do between two attachment points. If that straight line is completely parallel and centered to the femur and the tibia, from where the soft tissue attaches above to where it attaches below, everything is status quo and everything's straight. I keep having to kind of force normal on this abnormal model. But if everything is straight, up on straight, so you have a straight set of bones, femur and tibia, and then the soft tissues are straight right over the top of that, that's normal. Doesn't mean that these bones in a normal dog are even perfectly straight, but they're pretty darn close to it. And the attachments all line up. The patella sits nice and neutrally over this groove, and nothing happens. There's a lot of reasons why the patella can become medialized, or in less common cases, lateralized. Most patellar luxations are medial. And that's because most of the deformities that create it influence it to be medial. So the most common one that we address in surgery is where this piece of bone is. The tibial tuberosity often is more medial than it should be, and this model of the tibial tuberosity is medialized compared to where it should be. It's kind of pulled over to the inside. And that's the one that we most commonly correct, and we'll talk about that in a second. Less commonly, but one we should always be on the lookout for, is this curvature here, distal femoral varus. You can see that if the femur is curved in a bow-legged fashion, then the curvature is kind of escaping that normal straight path of the patellar mechanism. And that's a pretty intuitive reason why the patella can luxate. So if you see this on an x-ray, and you don't address this by doing a corrective straightening of the femur, then you're going to have a high chance of this coming back out. And then you can also have a concurrent or separate valgus of the proximal tibia, which can kind of have a similar effect. The ones we most often address at surgery, once we've excused ourselves from having to deal with any severe distal femoral varus, is the position of this tuberosity. So the first thing that we need to prioritize at surgery is getting this alignment better. If you can imagine, if we moved this piece of bone as it's attached to this tendon over to a neutral point that's centered over the femur, then it's going to not want to pull out as easily. So tibial tuberosity transposition is the name of the game with these surgeries typically. And again, I'm trying to force this on an abnormal, but hopefully you get the idea. How do we do that is a technical detail, but we cut the bone from about right here on the surface in front of all the internal joint structures down. And typically I like to leave a little bit of this bone attached, just enough so that there's still an anchor point here, because this piece of bone can be vulnerable to pulling by the muscle while it's trying to heal. So it's really nice to keep a nice powerful connection. We go almost all the way down so that we can still move this piece of bone, in this case laterally, and I'm emulating that just by pulling the tendon over here. But we'll move that piece of bone over with an attachment here, so it kind of just bends at the bottom until we get things centered right over. And at surgery we look for that. We just look for, what I usually do is just stand over the top, and I want to make sure that the patellar tendon looks very straight, parallel over the tibia, not that it's getting angled or pulled one way or the other. Once we get the tibial tuberosity into position, we'll place pins, because the pins are effective, especially with an attachment down here of the bone. Pins are really effective at resisting the tension of the pull of that muscle. So 2 or 3 typically pins that go through the tuberosity and into the back of the tibia. Oftentimes I'll start by placing what I call a buttress pin, which is just a pin alongside the cut piece of the tuberosity, and that just lets me hold the bone in its new position and be able to place the other fixation pins hands-free from front to back. So 1, 2, and then potentially one that's just on the side of the bone instead of through it. The orientation of the pins is important, because the more we angle the pins this way, which is kind of easier to do, the more susceptible they are to being pulled. Again, the muscle up here is pulling up and out. So if we angle the pins this way, the bone can be pulled off of the pins and just slide off in theory. But the more you angle the pins this way, especially as you get to 90 degrees or less from that pull, then the bone is being pulled against the rest of the bone instead of off of the bone, if that makes sense. So here we're kind of staked into the bone, and here it's kind of sliding in the same direction. So the pin orientation is important. We try to go acute angle to the patellar tendon. So that's the first step. It's not the first thing I do in surgery, because logistically it just comes after, but it's the most important thing. If you don't do that, then you're really still fighting against that situation. The other procedures just are adjuncts to that. And I can't emphasize this enough, but I'll keep doing it. If we don't fix the alignment and get things to relax into a neutral position, and we're just fighting and suturing and pulling, we're just pulling against the natural tendency. We need to alleviate the abnormal prior tendency. And that's a common theme in other surgeries too. If you can change the biomechanics first, especially if you can do it by manipulating bone that'll heal solid and never change, then you're going to have a much higher rate of success. But after we're done with that, technically before, because we do this first, is look in the joint and check that everything's okay in there. But the other things that we do most often deepen this groove. In most cases of patellar luxation, this groove is not normal depth. This model, I would say, is relatively normal, but a lot of times we'll see a lot less of a deep groove in there, more flattening. Is that why they get patellar luxation? No, they get patellar luxation because of the discrepancy that we keep talking about. But dogs that are born with that anatomy that creates this situation usually don't have a normal backwards pressure of their patella on their femur. And it turns out that it's the pressure of the patella on the distal femur here that stimulates development of a normal depth of a groove. So as more of a secondary aggravating consequence of the anatomical issue, oftentimes you get a shallow groove. So once we correct that, we can't make the groove develop again, but we can help deepen it. The key to deepening the groove is that as you do it, you don't want to remove the surface cartilage. I mentioned earlier that one of the problems with patellar luxation is that it wears the articular cartilage away. So we don't just want to dig it all out because we're trying to preserve that. If we're unhappy that the dog is grinding away cartilage, then the fix is not to keep grinding it away in surgery. So we do something to deepen this groove while maintaining the cartilage surface. There's different methods of doing that. The one that is most common in my circles, what I've been doing for a while, is what's called a block trochleoplasty. That just means that we take a rectangular, a block-shaped piece by cutting straight down from the edge of one side, so cutting down this way, and then same thing on the other side. So we're making a cut pretty deep on each side, and then we cut underneath through this way up and create a block-shaped piece that's hopefully about halfway, or give or take, the depth of this whole area. And we remove that piece temporarily. So we have a block of bone, including the cartilage covering, basically taking out this groove segment, and then we remove bone either from what was underneath there or from the piece itself. I'll oftentimes take a big chunk out and remove from that piece itself, and then put that less tall piece that still has the cartilage covering back in. So it sets back in, but because it's been shaved off underneath of some of the bone, it'll sit deeper in there. And that just gives us, now that we have better alignment, a better catch of that patella. So not only is it kind of neutralized, but it's just maintained and contained a little bit better. So it's a nice kind of synergistic set of techniques. And then the last thing that we do in a straightforward case of patellar luxation is, what's not shown in this model is there's sheets of tissue on either side of the patella. There's fascia, which is a strong connective tissue. Below that, there's joint capsule. And those, over time, if the kneecap's been going this direction medially over and over again, you might imagine, gets stretched out on this side. And on this side sometimes can get tight. So once we're doing all this other stuff, getting the groove better, getting everything aligned, there's some redundancy over here. That stretched out tissue kind of ends up being extra. And so it's nice when you're done with all that to tighten that up, so that you're, again, just supporting what you've already done and just helping maintain everything in a nice straight tight position. And the way that we do that is either or cutting a little strip of that extra tissue out so that we're back to a normal tight but not too tight amount, and suturing that back together in a pattern that helps us kind of tighten it up a little bit. And that's just kind of to taste, so to speak, to effect. And we just kind of feel as we go, as we're closing that up, and just make sure everything feels like it's right where we want it to be. It's tracking up and down, and it's obviously not coming out. And there's different ways that you test for that, through range of motion with internal and external rotation of the tibia. There's a lot of things you want to do just to get balance. And now that we've mentioned sort of the basics, this a little bit more technical stuff, the surgery is all about balance. It's not just about tugging things back over in the opposite direction. You can go too far in the correcting direction and cause a luxation in the other direction. You can be too focused on pulling one way or the other and not think about that there's also forces that are pulling backwards. So there's a lot of balance that happens between just getting everything kind of held and maintained in the right direction. In terms of diagnosis of patellar luxation, for those that are interested, most people talk about the different grades of this condition, and there's some little differences in how some people do it, but the most common, the one that I'm familiar with at least, is grade 1 being the least severe, is that the patella will go side to side within the groove but not come out of it. So that's grade 1. And again, there's more complicated schemes. Grade 2 is when the patella does come all the way out, but it goes back in and stays in most of the time. So it means just that the default position is to be in place, and then the non-default, the exception, is that it comes out, but it does do that. So those are a lot of the dogs that skip once in a while. Most of the time they're good. Grade 3 is sort of just the inverse of grade 2, which is that it can come out and it tends to stay out but can be put back in. So it just means that the default is out, but it can be reduced. This model is a grade 3 because I can hold it back in as I've been trying to do, but naturally wants to come out. And grade 4 is that it's out and it cannot be put back in. It's just kind of frozen in a luxated position. The prognosis with repair has a lot to do with the different grades, and also with deformities as a complicating factor. Also has to do with the size of the dog. So best case scenario is a low grade, grade 2. Grade 1s we don't operate a lot. Grade 2 plus or minus. In a small dog, I usually give a prognosis of about 85% in terms of being able to keep the patella in place. Because what's the 15%? In my mind, it's just that we're doing all these corrections, but we're really just trying to compensate for abnormal development. So there's never going to be 100% unless you could make the dog develop completely normally from the start, which we can't. So we're still, despite good success, compensating for abnormal development, and there are things that we don't deal with up here. There are subtle things that we don't deal with by doing things the same way every time that just result in sometimes, things finding their way out again like they wanted to be originally. That number for success goes down, or the failure rate for maintaining reduction goes up if you have these deformities, obviously, particularly if you don't address them. Bigger dogs tend to have a higher risk of reluxation, but that is the main complication, is having the patient reluxate. The other potential complications have to do with the pins being put in. They're smooth pins, they're not screws, so they're held in with friction, and over time they can work their way a little bit out towards the skin. And they're really close to the skin to begin with, so even if they don't migrate, they can stick out enough that they just cause a little irritation under the skin as the skin's moving over the top of it. So sometimes we'll have patients that have a really good result, keeping the patella in place. Everything heals just fine with the bone, but the pins are causing problems with or without migration. They get a little bump over their knee. They're kind of turning around to look at it every once in a while. And in those cases, we'll recommend removing the pins, because the point of manipulating the bone is that once we've moved the piece of bone over, secured it in place, and let it heal, it'll heal solid within about 2 months' time. And after that point, the pins are not doing anything anymore. They were just there to influence where the bone heals in its new position. So we can pull those pretty easily if we need to, if they're causing problems. In most cases, they stay in place. So the chances of having to remove the pins are maybe 1 out of 8 to 10, just depending on how bothered the patient is and how proactive a client wants to be, or how much they kind of worry about it bothering the pet when it's not obvious. The bone can fail to heal. That doesn't mean there's something wrong with the bone. Usually failure to heal a bone just means there's too much movement, which either means the pins aren't holding, or there's something that happened that causes the pins not to do their job anymore before the bone gets a chance to heal. It's a pretty uncommon complication. Definitely can go up quite high if the patient is active, because if the patient's active, then their muscle is pulling on this piece that we're trying to hold in a new position with pins. So activity restriction is super important after the surgery to just let that heal. But if we have pins that bend or break or the bone moves on us, then unless it's really mild, then we have to try to go back in and secure it, and it's never easier the second time. So exercise restriction is a real deal thing for this surgery, as it is with most bone surgeries. But overall, if there's a patient that is showing signs of this condition, and a lot commonly do, and a lot of people just kind of blow it off to like they skip, they're goofy, whatever, it's usually something that's causing pain to the patient. And everybody has their own cutoff in terms of which cases should have surgery, which don't need surgery. Some do it based on the grade. I think that if the patient is showing that symptom on a daily basis, then there's definitely a case to be made for fixing it, because they're rubbing on their cartilage every time that happens. And it's nice to do that earlier in life, because you can save a lot more of the cartilage than if you wait till they're older and they've been doing it for a while. Another little side note in terms of diagnosis for the vets and vet students out there is, if you have a patient that's becoming lame in adulthood, 3, 4, 5, 6+ years old, and they're limping constantly, not skipping, but even just in general, a dog that's an adult that presents for lameness and has patellar luxation, either previously diagnosed or you diagnose it, be very skeptical about that being the cause of the lameness. As we said before, skipping is the main symptom of patellar luxation. Not 100%. Some dogs can limp more continuously with patellar luxation alone. But most patients that present for patellar luxation present for skipping and present relatively early in life. If the patient was born with the anatomy that creates this problem, they were doing whatever they were doing with the problem until they were, let's say, 5 years old, and something made somebody want to bring them in at that point, which usually means something different is going on to prompt evaluation at that point. That something is most often cruciate disease. Doesn't have to be, but that would be the big thing to watch out for, is if you have a patient that comes in limping, adult, you feel patellar luxation, be skeptical about fixing the dog by fixing the patellar luxation, because usually just as a sort of a clinical entity, a clinical picture, there's going to be something else going on. Please let me know if you've watched this, if you have questions about any of that, questions about patellar luxation, but I hope that was helpful for pet owners, hope it was helpful for people that are studying this stuff, and thanks very much.